I'm Rory Sweeney. I'm a transport consultant in the Children's Hospital in Belfast. I'm just going to run through time critical transfers, and I suppose it's a term that gets bandied around a lot. But we're coming off the back of a traumatic brain injury talk, so that's one kind of time critical transfer. But I just wanted to get a little bit of interaction, hopefully at the start, if this does indeed function, and try to get people to think about what sort of conditions are out there that do require time critical transfers. Obviously, we've talked about a big group from the last talk, but is there anything else that people know of?
So in terms of what's coming up here, we're getting block shunt, surgical emergency, cardiac, high ammonia, surgical abdomen, shunt blockage, stroke.
And all sounds like good stuff. So sort of list of things that I've got as well. So yeah, I mean the neurosurgical emergencies are the ones that we probably consider most. So traumatic brain injuries being one, and block shunt is another big one for our population. Surgical emergencies, absolutely. I suppose just to highlight around this as well that not all time critical transfers are necessarily critical care in appearance. So something like testicular torsion presenting to an area where there's no surgical cover is time critical, but it might well not involve a critical care type of transfer. Cardiac ones, certainly your sort of transposition of great arteries with intact septums or obstructed TAPVDs. High ammonia is absolutely, and again, they look maybe slightly different in terms of what you're thinking about in terms of your transfer. And the other thing are kind of, it's always life or limb saving, isn't it? That's talked about in sight as well. So things like an acute compartment syndrome or vascular injury that might need to move. And again, those might look different from a kind of neurosurgical emergency in terms of the patient that you've got in front of you. With all transfers, this is the aim. The aim is that the right patient's taken at the right time by the right people to the right place, using the right form of transport, and receives the right care throughout. So throughout this, that's a sort of framework to be applied. It's not just that the idea of a scoop and run and just throwing them in with anybody who's there is not what we're aiming for with any kind of transfer, and in particular an unstable critical care transfer. So we need to consider who the patient is, why they're going and what they're going for, exactly where they're going to. So that needs to be clarified beforehand. Exactly how much time you've got. I'll give a sort of guide of what a time critical transfer should be, but there should be a little bit of consideration if some things you may be able to sort out a little bit more and other things you need to go sooner. Exactly how you're going to get there, and a little bit around the who. So in general, when we're talking about time critical transfers, it's the responsibility of the local team who need to transfer them. But occasionally, due to proximity or due to other issues around actually access to a vehicle, it may be that a transport team is the faster option to transport some of these patients, but we'll talk about that as we get through. So the objective with these transfers is that it should be a swift and safe transfer, and primarily you're focusing on three key areas that need to be sorted out to aim to depart your. So once a time critical transfer has been stated by a receiving team, you should be aiming to depart your unit within 60 minutes. And you've got these three areas: your patient, your equipment, and all of the communication that all need to be happening at the same time, in order that you're able to get everything sorted within 60 minutes to be able to leave. I'm just going to go through each of these areas in turn then. So obviously the patient, again, focusing more on the kind of critical patient who arrives in, so neurological or surgical emergency. You need to take a bit of time to stabilize your patient to make sure that the transfer can go smoothly. However, it's a balance. Do all of the things that will allow the transfer to happen, but don't dwell or don't delay for procedures which are not going to be necessary to facilitate a safe transfer. So things that are often talked about are delaying for central access for somebody who doesn't need it, or arterial access. Can you just insert an IO if something needs to be given via a central route, and then that will cut down your time on the ground in your DGH before you move? Can you get away with non-invasive blood pressure monitoring? Are you on something that requires you to have arterial invasive blood pressure monitoring? And having a systematic approach to this. So one part of your team should be focused on getting the patient stabilized, and it's probably useful if that part of the team is also the person who's going to be moving the patient so that they get a feel for how they're going to be on transfer. The checklist that I've got here is borrowed from the Leicester team and is available online. There are many of the transport teams that have a sort of time critical checklist to go through, broken up into the different components, but it's worth having something that you can go through systematically, because in all of these fraught situations when you're rapidly assembling a team to do something that they don't usually do, it can be easy for things to get missed along the way. So ensuring you've got a systematic approach, your A, B, C, D, E, to making sure that your child is stabilized. Next up is thinking about gathering up your equipment. So in most DGHs, there will be some kind of a critical care transport trolley, certainly within the DGHs in Northern Ireland. And sometimes they're very well maintained and very well stocked, and maybe even with too much stuff, and sometimes maybe slightly less so. So what you need to have whenever you're setting off is a trolley and a harness that you can secure the size of your child on. If it is a patient who is ventilated, you need to have an adequate transport ventilator, a supply of oxygen, making sure that you've got an anesthetic bag and circuit, as well as an ambu bag if you have any failure in your oxygen supply, a way to adequately monitor your patient throughout the transfer, with all of the bits of monitoring that you would need to have for this type of patient. Making sure that you've got some infusion pumps which are secured on your trolley. Transport bags, lots of places, especially in DGHs, will have transport bags that are set up for adult transfers. So depending on your size of patient, a lot of this stuff might be appropriate. Or if it's a very small patient, a lot of that might be completely inappropriate, and consider whether, if there's a neonatal unit, do they have a transport bag or a transport trolley that you might be able to use if your patient is, say, less than 5 kilos. And if you're not exactly sure what is in the transport bag that you've got available, always consider taking with you in a sort of an emergency airway pouch that you've put together yourself, knowing that you've got exactly the right tube sizes that you need, the right blades, suction catheters, or pharyngeal airways, all of the things you'll need if you happen to get yourself into an airway emergency en route. And then it's consideration of gathering up all of the things that you might need for whatever might go wrong, condition dependent. So think of the two main things that you're concerned about happening on the way, and make sure that you're prepared for exactly those emergencies. Making up all emergency fluids and drugs before you go. If you think that you might need an inotrope infusion en route, make it up, have it run through, and possibly even attached before you go, rather than setting off without it and then finding that you're having to make something up in the back of a vehicle. The ambulance environment is not the place to easily make up emergency drugs, and you've got a very limited team. So trying to do as much as you can before you set off to make sure that you're ready, but equally don't be delaying for unnecessary things. So it's again striking that fine balance. The important thing about your trolley is you don't want to just be meeting your trolley for the first time whenever you're setting off to do a transfer like this. So within your hospital, within your department, do you know where your trolley is? Do you know what's on it? Do you know how to use all of the things that are on it? Do you know how to set up the ventilator circuit, for example, and run the pre-op checks? Lots of places still have oxylogs attached to their transport trolleys, but also have Hamilton ventilators available in some areas. And the bracket for connecting the two ventilators is the same, but Hamilton ventilators would be our recommended ventilator for particularly ventilating patients under 10 kilos. The oxylog really struggles, even with the smaller circuit, to ventilate well at the smaller end of the scale. So it is possible to remove the oxylog and put on the Hamilton. Do you know how to do it? Does somebody know how to set the Hamilton up? Do you know who maintains it? So is there somebody regularly checking these? Is it somebody who's a critical care scientist? within the ICU? Is it somebody in the emergency department going through it? Is it somebody from theatres? And the transport bags, is there a checklist for things that are in it? Do you know within the hospital you're working in that somebody regularly goes through the transport bags to check that it's been restocked and that the stuff that's in it hasn't all gone out of date because nobody's actually moved it or used it in a couple of years? And again, as with checklists, trying to have something in front of you to try and offload some of the bandwidth for whenever you're in an emergency situation. So there are resus drug calculators. So we at NISTAR have one available on our website, and I'm sure there are equivalents amongst the other transport teams, and sort of a spreadsheet where you can put in the child's weight and get all of your emergency drugs. And likewise, through the Paediatric Emergencies apps, the Paediatric Emergencies itself has condition-specific drug dose calculators, and if you look at the PICU calculator, it will give you all of the sort of emergency drugs and infusions that you would need for a child. Once you plug in their weight, it'll tell you how to make them up and what rates they should be run at. And again, if it's something that you're not familiar with doing and you're in an unfamiliar environment, it's much easier to try and offload a little bit of that bandwidth by having something in front of you. So then the next big thing is your communication. So for something like this, there's a lot of calls that often need to be made within a very short space of time, and designating somebody from the team to go off and perform all of the communication can be very useful. But obviously then that means that it's not, that often isn't the person who's directly looking after the patient. So there's a little bit of difficulty around that. Some phone calls to be made at your referring hospital. So in neurosurgical emergencies, the advice is that a CT should be performed in less than 30 minutes. So somebody arrives in, you're suspicious of a raised intracranial pressure from a traumatic brain injury or from a blocked shunt. Some phone calls might need to be made very rapidly in your department in order to get your CT performed. Then phone calls to neurosurgery and anesthetics, all within a very short space of time. Once a time critical call has been declared, then there are calls to potentially your PICU that you're trying to transfer to your transport team, to theatres, and then last but not least, a call to ambulance control. And it can be very difficult, obviously, to get all of these things coordinated, and for all of the people to get all of the right information in a streamlined sort of manner. So even though this is time critical and a lot of the calls, the transfer itself will have to be done by the local team, the transport teams can still offer an awful lot of help. So most of the transport teams around the UK will now have a single point of contact to phone into, which will be able to offer clinical advice. We'll have some kind of conference calling facility to bring in the specialist teams, to bring in theatres, anaesthetics, PICU all in together in one call. Or if there's decisions to be made around which intensive care they need to go to, often that can be made through one phone call through the intensive care team, who can coordinate these things rather than having to phone different places to ask for beds. And then leaving it up to them to coordinate things at the receiving centre. So though you might be through to the PICU, making sure that getting a bit of the assistance from the transport team to offload some of that organisation with discussing with theatres, making sure that theatres are cleared and ready, or if it's a metabolic emergency and you're coming to intensive care and for filtration, to make sure that all those discussions have been had and everybody knows when the patient's going to arrive and we're all set up for them when they come in the door. In terms of calling for ambulances, again, not necessarily something that people will have had to do an awful lot, depending on the unit that you're working in. This was the more recent guidance from the Northern Ireland Ambulance Service, trying to improve its response times for interfacility transfers. So when it's an emergency and you dial 999, in general, you just get through to a call handling service, and they have a series of questions to go through, just like if you're calling from the community. Is your patient breathing and are they responsive? Which can be obviously slightly confusing when they're ventilated. So you do have to state that this is a time critical pediatric transfer, and hopefully there's a better understanding now when you phone through to ambulance control of what that means. But if there's any difficulty whenever you're speaking to the person, the initial person at the call handling desk, There is always a paramedic available to speak to within any ambulance control centre. And if you need to get sort of more of a clinical discussion to state why this is such an urgent transfer, you can ask to speak to the duty paramedic in order that you can definitely make sure that your call is escalated. As you can see there, the level 1 interfacility transfers, the response time should be 8 minutes after you make the call. However, we've had a lot of difficulty in Northern Ireland, and I'm sure that these problems aren't isolated with us, with ambulances getting a bit stuck trying to offload in emergency departments, and our response times have often been a bit worse than that. So very important to document the time that the call was made. Very important to phone early. So as soon as a time critical transfer has been stated, that's the time to phone for ambulance dispatch to make sure that somebody's there waiting rather than waiting until you're ready to go. And the other important thing is they should be able to clarify an estimated response time with you at the time of the initial call. And if it sounds like there's going to be a significant delay, maybe worth phoning back to your transport team to say, actually, we're not going to get a frontline vehicle and you might be here quicker. And the other person who it's worth talking to in these situations is, particularly during the daytime, there's a hospital ambulance liaison officer, or a halo, who usually runs out of the emergency department, and they will have a better oversight of what ambulance waits are outside, and sometimes they can free up frontline ambulances by getting somebody moved into the emergency department to free up a vehicle for you to be able to go on your transfer. Very important whenever you're on that call, just to clarify exactly where they're collecting from. So if you're in the emergency department, but the plan is to go to CT, go to theatre to get them on the trolley, it's important that you clarify exactly where they're coming to and exactly where you're going to as well, so that they know which way around they have to go to get into places, particularly out of hours when different gates can be closed. The other part of this is, if you need to have a specific crew, this is the time to ask for it. So not all paramedic crews are equal. So you have emergency technicians and paramedics both, and sometimes you can have a 2-person technician crew or 2-person paramedic crew, or a combination of those. So paramedics can do a bit more in terms of an emergency, so they can give more drugs and give fluids. Technicians are a bit more limited in what they're able to perform. So even if you don't need somebody in particular, it's always worth clarifying when your crew arrives exactly who they are and what they can do, so that if an emergency should occur whenever you're en route, that you know what they're able to help with and what they're not able to help with. For example, if you're moving and you have a cardiac kid or somebody who's likely to have an arrhythmia, um, you're likely to be using the defibrillator in the back of the ambulance, because you won't have most trolleys don't have a defibrillator on them. So it's worth clarifying with the crew about whether they're happy to use it, which they will be, but just to kind of have those conversations with them when they arrive to keep everybody on the same page. So then, once you've sort of got all those things sorted, we're talking about trying to get out of your department and get on the road. So when assembling your team, there is a decision to be made around who goes. A lot of this will be guided by who's available, but a big question is about who's qualified. And just again, as I said earlier on, we've moved away from the days of kind of the most junior member of staff, the most dispensable person on shift, being tossed in the back of an ambulance with somebody who's critically unwell in order to rush them down the road. So it should be the most qualified person. That then does beg the question of who then is going to backfill. So if you're taking away your senior anaesthetist and pediatrician, for example, is there somebody who can provide hospital cover? And that needs to be sorted as part of the process. And then what time is it? So if shift change is happening in 5 minutes, is it better to wait 5 minutes for fresh people to come in? And that maybe depends on the length of the journey, and also the capabilities of who's coming on and who will be going off shift. So there are considerations to be made around that. This is a version of the STOP tool, so a safe transfer of pediatric patients tool, just to sort of highlight the recommendations for a time critical level 1 to 3 transfer. So what's recommended is usually an anaesthetist, because we're assuming that they're going to need ventilatory support, a nurse, and that person who is transferring them, anaesthetist or otherwise, needs a senior airway and pediatric resuscitation competent doctor. And then your appropriately trained ambulance crew should be the people transferring. Also, just states on this about kind of less critical care, but also time critical transfers. So, for example, a testicular torsion, if agreed with the receiving team and that it doesn't delay treatment and the parents have been updated, it could be appropriate that the parents might be the quickest people to transfer. But obviously, ideally, with all of these, you'll want to go in a frontline vehicle. So, just as you're getting ready to set off, a few other important considerations. Do you know exactly where you're going? So you might be going to a hospital that you're unfamiliar with um, at a difficult time of day. Oftentimes the theatres and, for example, the emergency department are quite a distance away, and the best entrance for you to get into might not be where the ambulance crew usually go to. So if you can give them exact details of where you need to go, you might get better access to where you need to get to. Do you know how you're getting in? So again, doors can be locked, gates can be down, barriers can be down. Do you have somebody who you can contact in the receiving unit to make sure if you're struggling to get in, to make sure that they know that you're there and you can get in? And do you know who to call in an emergency? So if you're setting off, is it the transport consultant that you're phoning? Is it somebody in PICU that you need to get advice from? Do you have a direct line to contact them through? And whenever you're setting off, then you updated the team that are receiving. So do they know we're running some infusions and you think you're going to run out of them, or basically run out of them by the time you arrive? Make sure that they know what you've got. In terms of infusions, you should always be traveling with kind of double what you think you need, just in case there are any delays or ambulance failures on the way. But obviously, unforeseen circumstances can mean that you'll be in slightly short supply, and just keeping an open line of communication with the receiving team or the transport team who are aware of the patient is really important to update them on your way. Lastly, I suppose we'll talk about this issue around using lights and sirens. So for these patients, obviously we're trying to get them down the road quickly, and the temptation is that because it's time critical, you turn on your lights and sirens and go as fast as you possibly can in order to get them there as quickly as you possibly can. However, there's a considerable amount of evidence that shows that using lights and sirens doesn't really save a huge amount of time. Sort of the maximum time saved was about 6 minutes in most of the studies that have been done, and that was kind of in rural areas, uh, versus usually about 2 to 2.5 minutes within urban areas. And your risks of accidents increases massively, so about a fivefold increased risk of accidents. But more importantly, these are patients who are critically unstable. We're talking about traumatic brain injuries before, and um, the impact of raised intracranial pressure on your cerebral perfusion pressure, and the physiological impact of traveling with lights and sirens at high speed can be huge on your more unstable patients. So if you've got somebody with a traumatic brain injury and you're traveling along as fast as you can, and then you suddenly have to brake, that will cause a massive surge in their intracranial pressure. And equally, then, as you accelerate rapidly to take off, that will cause an episode of hypotension and hypoperfusion, both of which will have potentially drastic impacts, especially if you're doing that multiple times during a journey. So the recommendation for lights and sirens now is that whilst they can be used, really they should only be used for kind of progressive movement through traffic. So it's to keep you moving at a steady pace, but ambulances shouldn't be aggressively driving. And it's important to clarify that with the paramedics. So they're going to be turning up with a view that this is life or death. They're going to go as fast as they can, and they usually will ask about the use of lights and sirens. So yes, to go on blue lights, but really only to go smoothly on blue lights, and make sure that they're aware that you don't want them to go as fast as possible, because it's potentially could have very detrimental effects to your patient. Summary then, we're aiming for swift but safe transfers, and that is all of your organization before you need to leave then. So you might need to split your team up to make somebody's sorting out your patient, somebody's away gathering up all the equipment, getting everything sorted so that there's no delays once your patient is stable, and that somebody's taken on ownership of all of the communication that needs to be happening, and that includes an early call to ambulance dispatch to make sure that they are standing at the end of your bed waiting and that there's no delays to your departure. So once everybody's ready, you should be out the door. That's not the time to be phoning your ambulance. And having a couple of slightly irate paramedics tapping their watch at the bottom of the bed is a good way to get everybody sorted to go. Transport services are a useful tool to help you coordinate. So it is important to, again, coordinate with them nice and early. And often you can offload a little bit of the communication to sort out some of the things at the receiving side, and a really useful resource for clinical advice as well. And again, to reiterate, steady journey is what you're looking for rather than going like the clappers, because it can be very harmful to your patient.